It's quite something, isn't it? You see a small sore in someone's mouth, and it seems so straightforward. But the material you shared really shines a light on how these oral ulcers, despite looking similar, can stem from a surprisingly wide range of causes. We're talking about everything from, a simple accidental bite to indicators of much broader health issues.
That's a key point right from the start. What became clear from looking at this medical lecture in the textbook chapter
Mm.
is the sheer number of different pathways that can lead to the same result, basically a break in the oral lining.
Mhm.
And our goal in this deep dive is to, well, explore this complex area, highlighting the crucial differences so you gain a solid understanding without feeling like you're, studying for a medical exam.
Okay, let's jump in with what we likely encounter most often. Those reactive ulcers caused by some kind of trauma. I mean, everyone's had that moment of accidentally biting their lip or tongue,
Oh,
right?
absolutely.
The sources confirm these are the most frequent injuries to the mouth's soft tissues, typically showing up exactly where you'd expect those vulnerable spots like the inner lower lip, the tongue, and that lining of your cheek, the buccal mucosa.
Precisely. And as the sources point out, not all trauma is accidental. We also need to consider iatrogenic causes, things that can happen during dental or even medical procedures.
Right.
Then there are chemical irritants from highly acidic or alkaline substances, other irritants, and even allergens. And who hasn't heard of someone holding an aspirin against a toothache? That can lead to a direct chemical burn, described as coagulative necrosis, almost like how a strong acid would damage tissue.
Right, that makes sense, like a chemical burn, basically. And what about those pizza burns on the roof of your mouth? I always thought those were really common.
Yeah, me too.
But one of the sources actually noted that intraoral ulcers from thermal burns are relatively uncommon. That kind of caught me off guard, considering how often we, well, talk about them.
It's a good reminder that our everyday experiences don't always align perfectly with, medical statistics. While a hot pizza can certainly sting, it might not always cause a true ulceration, technically.
Mm-hmm.
Now, the sources help us distinguish between acute and chronic traumatic ulcers based on their clinical presentation, what they look and feel like.
Got it. So acute think a recent injury. These tend to be painful, red, possibly a little swollen, with that characteristic yellowish-white film, a fibrinous exudate, and a reddish border around it, that halo.
Yeah, the classic look.
But then there are the chronic ones, the ones that have been hanging around for a while. These might not even be very painful. They have this yellow membrane, and the edges can become thickened, almost like a protective layer, that hyperkeratosis. You might even feel some firmness underneath, that induration, as the body tries to repair the damage with scar tissue.
What's insightful here is looking at the microscopic picture, what's happening at the cellular level. In an acute ulcer, you'll see a lot of neutrophils. Think of them as the body's immediate cleanup crew within that fibrin network.
Okay.
But in a chronic ulcer, the picture changes. You see granulation tissue, which is essentially new tissue trying to fill the gap, along with other immune cells like macrophages and even eosinophils, indicating a more prolonged healing process.
And the key insight with these traumatic ulcers seems to be pinpointing the cause. If you can identify what's irritating the tissue and, eliminate it, those acute cases usually resolve on their own.
Usually, yes.
But here's where it gets really important. The sources stress that if a suspected traumatic ulcer doesn't heal within 2 weeks, that's a significant red flag. A biopsy is absolutely necessary to rule out something more serious, like neoplasia or an infection. That's crucial information for anyone to keep in mind.
Absolutely. That 2-week mark is a critical point. You can't just ignore it. Now, let's transition to ulcerative lesions caused by infections. And given its relevance in dental practice, it's probably logical to start with syphilis.
Okay, syphilis. We know it's caused by the bacterium Treponema pallidum, a type of spiral-shaped bacteria, a spear-shaped. And it's primarily spread through sexual contact, but the sources also mention transmission via infected blood transfusions, which would bypass the initial stage, and also from a pregnant person to their baby, known as transplacental inoculation.
Exactly. And the disease progresses through distinct stages, each with its own set of potential oral signs. In the primary stage, you get that hallmark lesion, the chancre. It's described as a painless, firm, indurated ulcer with rolled or raised edges at the site where the bacteria entered the body.
Painless. Okay.
Yeah, usually painless. While most commonly found on the genitals, it can definitely occur on the lips, inside the mouth, even on the fingers, and it looks quite similar regardless of location, typically without any pus-like discharge, no exudate. What's notable is that it heals spontaneously within 3 to 12 weeks, even without treatment, although the infection is, of course, still present in the body.
Right.
This silent resolution can be deceiving, potentially leading individuals to believe they are no longer infected.
That silent healing almost makes it sound more insidious because someone might think they're in the clear when they're absolutely not. Then comes the secondary stage, usually a few weeks later, with more widespread symptoms like fever, flu-like symptoms, skin rashes and lesions on mucous membranes, and swollen lymph nodes. What are the oral signs we should be aware of in this stage?
In the secondary stage, the oral lesions aren't usually deep ulcers like the chancre. Instead, they often appear as mucus patches, which have a sort of whitish mucoid surface. You might also see split areas at the corners of the mouth, the labial commissures, and even deep grooves developing on the sides of the tongue, sometimes called snail track ulcers.
Okay.
And similar to the primary stage, if left untreated, these secondary symptoms will also disappear on their own eventually.
Again, that resolution without treatment, just masking the ongoing infection. Then we move into the tertiary stage, which the sources highlight as the most serious. This can take years to develop and can affect really vital systems in the body, like the brain and heart.
Exactly. Tertiary syphilis can involve the central nervous system, the cardiovascular system, and it can cause these things called gummas. These are localized areas of significant inflammation and tissue destruction necrosis that can occur in almost any organ, including the palate. When a gumma develops in the palate, it can be quite destructive, potentially leading to a perforation, basically an opening between the mouth and the nasal cavity.
Wow. And then there's congenital syphilis, which is just devastating. If an infected mother transmits T. pallidum across the placenta, what are the consequences for the baby?
Congenital syphilis can result in what's known as Hutchinson's triad. It involves problems with the eyes, specifically the cornea, leading to interstitial keratitis, eighth nerve deafness causing hearing loss, and very distinctive dental abnormalities.
Ah, the dental signs.
Yes, we're talking about incisors that are notched or shaped like a screwdriver, and molars that are described as mulberry molars having an irregular, bumpy chewing surface.
Mm-mm.
These dental issues arise because the infection actually affects the developing enamel organ of the teeth.
The sources also touched on how the body reacts to this infection at a tissue level. It mentioned proliferative endarteritis and a significant infiltration of plasma cells. And those gummas in the tertiary stage show tissue death, necrosis, and a large number of macrophages, which I suppose is why it can sometimes be confused with TB.
That's right. Proliferative endarteritis, by the way, refers to inflammation in the small blood vessels that leads to a thickening of their walls, potentially restricting blood flow to the tissues. It's an important feature.
Okay, that helps distinguish it. And speaking of diagnosis, the sources outlined several key tests. Dark field microscopy of fluid from active lesions, special silver stains or immunologic staining of tissue samples, and blood tests that detect antibodies against T. pallidum, serologic tests.
Correct. Those are the mainstays.
And the good news, if there is any with syphilis, is that the treatment is relatively effective. Penicillin. It sounds like that's still the primary treatment, though there are alternatives for allergies.
Yes, penicillin remains the treatment of choice. Alternatives like doxycycline or azithromycin can be used for individuals who are allergic. But the crucial thing is early diagnosis and treatment to prevent progression to those more severe, dangerous stages.
Absolutely. Untreated syphilis can have serious and long-lasting consequences. Okay, now let's switch gears to another bacterial infection, actinomycosis. This one's interesting because it's caused by Actinomyces israeli, which is actually a common bacterium found in many people's mouths, part of the normal flora.
Right, it's usually harmless. So even normal oral bacteria can cause serious infection given the right opportunity, emphasizing the importance of, oral hygiene and prompt management of oral trauma or infections.
So if it's normally present, what triggers an infection? The sources mentioned it usually occurs after some kind of disruption, like trauma, surgery, or maybe a previous infection. Things like tooth extractions, gum surgery, even other oral infections can create an environment where it can, well, gain a foothold and thrive.
Exactly. And it's important to remember that it's not contagious. You don't catch it from someone else.
Good point.
The clinical presentation is often a swelling in the lower jaw area, the mandible, which can sometimes be mistaken for a typical pyogenic infection like a dental abscess. However, this swelling tends to become very firm, indurated, and it can eventually lead to the formation of draining channels called sinuses that open onto the skin of the neck. The sources describe these skin lesions as having a very characteristic woody hard feel.
Woody hard, okay.
Involvement of the upper jaw of the maxilla is less common, but it definitely can happen.
And one of the hallmark signs of actinomycosis is the presence of these sulfur granules in the pus that drains out. What exactly are those? Are they actually sulfur?
No, not really sulfur. Sulfur granules are essentially yellowish clumps or collections of the Actomyces israeli bacteria themselves, tangled up with tissue debris and immune cells. They just look yellowish. On an X-ray, the infection typically appears as a dark area, or radiolucency, often with irregular and poorly defined borders.
Right.
Microscopically, you'll see granulomatous inflammation with a central area of pus formation, an abscess, and those characteristic colonies of the bacteria.
So diagnosis relies on actually identifying the organism, either by directly examining the pus for those granules, looking at tissue samples under a microscope with special stains, or by culturing the bacteria. That can be tricky since it's anaerobic.
Correct. Identification is key.
Hey?
And treatment sounds like it can be a long-term process.
Yeah, it often is. Long-term, high doses of penicillin or related antibiotics are the main treatment. Sometimes you need intravenous antibiotics initially, followed by month, maybe even up to a year of oral medication.
Wow, that's a commitment.
It is. And often, draining any abscesses, removing any dead or infected tissue debridement, and even surgically removing any persistent sinus tracts are needed to help the antibiotics penetrate and work effectively. That makes sense, physically removing as much of the infection as possible and ensuring the medication can actually reach the remaining bacteria. All right, now let's move on to tuberculosis, or TB, caused by Mycobacterium tuberculosis. This one definitely raises concerns, especially in a dental setting with procedures that create aerosols.
Absolutely. TB is an aerobic bacterium, meaning it needs oxygen and it doesn't form spores. It has a unique waxy outer layer that makes it resistant to regular stains, so it requires special stains like Seal-Nielsen to identify it as an acid-fast bacillus. And as you said, it spreads through tiny droplets in the air, which is why it's such a significant concern for transmission, especially for healthcare workers.
We all know the classic symptoms of active TB. A persistent cough lasting 3 weeks or more, maybe chest pain, loss of appetite, chills, coughing up blood, fever, night sweats, fatigue, and weight loss. But the sources also pointed out that many people can have latent TB without showing any of these active signs.
That's a critical distinction. Someone can be infected but not actively sick or contagious. Oral lesions from TB can occur either through direct contact with infected sputum coughed up from the lungs, or, less commonly, through the bloodstream spreading from the lungs or another site. So oral TB is often secondary to lung TB, or a reactivation of a latent lung infection.
And what do these oral TB lesions typically look like? The sources describe them as indurated, so firm, chronic, non-healing ulcers that are usually painful. Common locations seem to be the tongue and palate, and in more advanced cases, it can even involve the bone, leading to tuberculous osteomyelitis.
That's right. And it's important to understand that a positive skin test, like a PPD, or a finding on a chest x-ray, only indicates that someone has been infected with M. tuberculosis at some point. It doesn't necessarily mean they have active disease right now.
Right. Latent versus active.
Exactly. Active disease is characterized by those systemic symptoms we discussed: fever, night sweats, general unwell feeling, malaise, weight loss, cough, maybe coughing up blood, hemoptysis, chest pain, and so on. Microscopically, TB lesions show a specific type of inflammation called granulomatous inflammation, often with a central area of cheesy-looking necrosis called caseous necrosis. You'll also see characteristic cells called epithelioid cells and Langerhans giant cells. And you absolutely need that acid-fast stain, the Zeal-Nielsen or Pfeiffer stain, to confirm the presence of M. tuberculosis bacilli within the lesion.
So when you see a persistent, chronic, non-healing ulcer, especially if it's indurated and painful, you have to consider TB in your list of possibilities, your differential diagnosis, along with things like primary syphilis, maybe deep fungal infections, or even cancer.
Definitely. And treatment for active TB is a long and involved process, right?
It is, typically involving a combination of several antibiotic drugs like isoniazid, rifampin, pyrazinamide, and ethambutol, taken for 6 to 12 months or even longer, depending on the case, and drug resistance.
It requires strict adherence.
Absolutely. The good news is that if it is TB causing the oral ulcer, the oral lesion should improve and resolve as the systemic infection is treated effectively with the appropriate anti-TB medications. Okay, now let's talk about those deep fungal infections. The sources listed a few: histoplasmosis, coccidioidomycosis, blastomycosis, mucormycosis, and cryptococcosis. It sounds like oral involvement is usually a consequence of a primary infection elsewhere in the body, after the lungs. These are generally less common than bacterial or viral issues, but still important to recognize, especially in individuals with weakened immune systems.
That's correct. Oral infections from these deep or systemic fungi typically occur either by direct implantation of infected sputum from the lungs or through hematogenous spread, meaning the fungus travels through the bloodstream from a primary site of infection, most frequently the lungs. In some instances, particularly in immunocompromised patients, the oral lesion might actually be the first noticeable sign of a disseminated fungal infection.
And the initial symptoms often point back to that lung involvement, right? Things like cough, fever, night sweats, weight loss, chest pain, maybe even coughing up blood, similar in some ways to TB symptoms.
Exactly. So a primary fungal infection starting in the mouth without any lung involvement is quite unusual for these particular organisms. You usually expect a preceding pulmonary infection.
Makes sense. At a microscopic level, these infections also tend to trigger a granulomatous inflammatory response, much like TB. You see immune cells called macrophages and multinucleated giant cells being the dominant players. However, in some fungal infections, like blastomycosis, you might see more pus formation, more neutrophilic infiltrate alongside the granulomas.
Again, the differential diagnosis for a chronic, non-healing oral ulcer includes these deep fungal infections, but also, oral squamous cell carcinoma, chronic trauma that just isn't healing, oral TB, and primary syphilis. They can look quite similar initially.
So how do you definitively identify a deep fungal infection?
Definitive diagnosis requires either growing the specific fungus in culture from a sample of the lesion or identifying the characteristic fungal organisms directly under a microscope in a tissue biopsy, often using special stains like PAS or GMS.
Okay, biopsy and special stains are key, and treatment involves antifungal medications.
Yes, medications like ketoconazole, fluconazole, itraconazole, or the more potent amphotericin B, often given intravenously for serious infections. The specific medication and the duration of treatment depend heavily on the type of fungus identified and the severity of the infection, and especially on the patient's immune status. More aggressive treatment is almost always necessary for those with compromised immune systems, and in some cases, particularly with mucormycosis or extensive tissue destruction, surgery might be needed to remove infected and necrotic tissue.
Right, that aggressive surgical debridement for mucormycosis is often critical. Okay, we've covered a significant amount of ground with the infectious causes. Now let's delve into the immunologic side of things, starting with something extremely common, aphthous ulcers or canker sores. It's interesting how our own immune system, which is designed to protect us, can sometimes go awry and attack healthy tissues in the mouth, leading to these conditions.
Aphthous ulcers are indeed a fascinating and often frustrating area. While we don't have one single definitive cause, there's strong evidence pointing to a localized problem with the immune system, specifically involving T lymphocytes, T cells. It seems like there's an exaggerated immune response to some kind of trigger.
And what are those potential triggers?
Well, other factors such as hormonal fluctuations, stress, minor physical trauma inside the mouth, and even sensitivities or allergies to certain foods like chocolate, nuts, or acidic fruits have been investigated as potential contributing factors or triggers in susceptible individuals. But the core issue seems to be that immune dysregulation.
And a really key distinction that the source has highlighted, a crucial way to tell them apart from herpetic ulcers, cold sores, is that aphthous ulcers do not start as vesicles, those small, fluid-filled blisters.
Absolute critical point. No preceding blister.
They typically appear on the movable parts of the oral lining, the inside of your lips and cheeks, buccal and labial mucosa, the tongue, the soft palate, the floor of the mouth. It's generally less common to see them on the attached gingiva, the gums tightly bound to the bone, or the hard palate.
Right, that location preference is another helpful clue. Those areas attached to gingiva, hard palate, are more typical sites for secondary or recurrent herpetic ulcers.
Exactly, which again helps in distinguishing them. However, it's worth noting that in individuals with significantly compromised immune systems, like in advanced HIV or AIDS, aphthous ulcers can sometimes be larger, more persistent, and can occur almost anywhere in the mouth, even those less typical sites.
That's a very important exception to remember. And the sources describe three main clinical forms of aphthous ulcers: minor, major, and herpetiform.
Right. Minor aphthous ulcers are the ones most of us are familiar with, usually just one, maybe a few small, painful, oval-shaped ulcers, typically less than half a centimeter, maybe up to 1 centimeter in diameter. They have that characteristic yellowish-white fibrinous base and a distinct red border or halo. They usually heal up within about 7 to 10 days, maybe up to 14 days, without leaving a scar.
But wow, can they be painful, especially if they're on the tongue or somewhere that moves a lot?
Oh, definitely. The level of pain can seem quite disproportionate to their small size. Then you have major aphthous ulcers, sometimes called Sutton's disease or periodontitis mucosa necrotica recurrens. These are larger, usually over half a centimeter, sometimes even several centimeters across. They are generally more painful, penetrate deeper into the tissue, and they tend to last longer, sometimes looking like little craters.
And because the inflammation goes deeper, they can take much longer to heal, sometimes up to 6 weeks, and they often result in scarring because of that deeper tissue destruction. They also have a tendency to recur more frequently than minor aphthae and can sometimes be associated with underlying systemic health issues, particularly in those with weakened immune systems, like HIV infection. They often appear on the soft palate, tonsillar pillars, or labial mucosa.
And finally, the herpetiform type. The name can be a bit misleading, can it? Because they're not actually related to the herpes virus at all.
Not at all. The name just comes from the fact that they resemble a primary herpetic outbreak because you get numerous small lesions. They show up as clusters, sometimes many dozens, even up to 100, of tiny little pinpoint ulcers, maybe 1 to 2 millimeters each. And again, crucially, they do not start as blisters or vesicles. They can occur anywhere in the mouth, including the movable mucosa, but also sometimes on the attached gums and palate, which can add to the confusion with herpes.
And are they painful?
Yes, they are typically very painful due to the sheer number of lesions, but the individual ulcers usually heal relatively quickly, often within 1 to 2 weeks, generally without scarring.
Looking at the microscopic level, the histopathology of aphthous ulcers, the findings aren't very specific, are they? It's not like you see something unique that screams aphthous ulcer.
No, it's described as non-specific ulceration. You mainly see a mix of inflammatory cells within the connective tissue beneath the ulcer base. Initially, you might see more neutrophils, but then lymphocytes, particularly T cells, predominantly CD4 helper T cells early on, then more CD8 cytotoxic T cells later, along with macrophages and mast cells, become more prominent.
Mhm.
This collection of immune cells really supports the idea of an immune system-mediated process.
So when trying to determine if it's an aphthous ulcer or something else, especially a recurrent herpetic lesion, the patient's history is absolutely key. Asking about whether there were blisters first is critical.
Definitely. The absence of initial vesicles strongly points towards aphthous, and the location can also be a helpful clue. If the ulcers are exclusively on movable mucosa, it leads towards aphthous. If they're primarily on the attached gingiva or hard palate, that's more suggestive of a recurrent intraoral herpetic infection.
Right. So what about managing these? For minor, occasional aphthous ulcers, often all that's needed is maybe just avoiding irritating foods and using a gentle, bland mouth rinse, right? Maybe some topical anesthetic for pain.
Exactly. Often benign neglect is sufficient or just symptomatic relief with topical anesthetics like lidocaine or benzocaine. However, for more severe, frequent, or debilitating cases, more active treatment might be needed. Systemic corticosteroids, like a short burst of prednisone, might be considered for very severe episodes, but that's usually reserved for major aphthy or widespread herpetiform types.
And topicals.
For mild to moderate issues, topical corticosteroids are usually the first line of active treatment. Things like fluocinolone or clobetasol gel applied directly to the ulcer can help reduce inflammation and speed healing. And for particularly troublesome, large, or persistent lesions, especially major aphthae, an injection of a steroid like triamcinolone directly into the lesion base can provide significant relief and accelerate healing.
That makes sense. And then there was that interesting point about tetracycline.
Yes. Intriguingly, the sources mention that topical tetracycline or doxycycline suspensions, basically mixing the contents of a capsule with water and rinsing, can actually speed up the healing process. And the thinking is, it's not because they're killing bacteria, but because these antibiotics also happen to inhibit enzymes called matrix metalloproteinases, or MMPs.
MMPs, those are enzymes that break down tissue, right? Like collagen.
Exactly. So by inhibiting MMPs, the tetracycline rinse might help prevent further tissue breakdown and allow healing to proceed more quickly. They even described a specific rinsing regimen. Swish for a couple of minutes and then spit out several times a day. It's a non-antibiotic effect of an antibiotic.
That's fascinating, using an antibiotic for its anti-inflammatory or anti-enzyme effect. Now, the sources also mentioned a few other immunologic conditions that can lead to oral ulcers, sometimes looking similar to aphthous ulcers.
Right.
Go Behçet's syndrome.
Right, Behçet syndrome, sometimes called Behçet's disease. It's a rare, chronic, multi-system inflammatory disorder a type of vasculitis, really that can affect various parts of the body. We're talking the GI tract, cardiovascular system, eyes, uveitis, retinal vasculitis, central nervous system, joints, arthritis, lungs, and skin.
And oral ulcers are a key feature.
A very consistent finding, yes. Recurrent oral aphthous-like ulcers are present in virtually 100% of patients and are often the first sign. They look very similar to common aphthous ulcers, but tend to be frequent and multiple. It seems to have a genetic predisposition linked to HLA-B51 and is more common in certain geographic regions, particularly along the ancient Silk Road, think Turkey, Japan, Korea, and the Eastern Mediterranean. For our purposes, the key triad is recurrent oral ulcers, plus potential genital ulcers and eye inflammation.
And microscopically.
Microscopically, the lesions often show a prominent infiltration of T lymphocytes and signs of vasculitis, inflammation of the blood vessels, which is characteristic of the underlying disease process. Treatment typically involves systemic medications to control the widespread inflammation, often starting with corticosteroids and potentially adding other immunosuppressants like azathioprine or cyclosporine, depending on the severity and organs involved.
Then there's Reiter's syndrome, which sounds like another condition affecting multiple systems, now often called reactive arthritis.
Yes, reactive arthritis is probably the more current term. It's an acute condition typically triggered by an infection elsewhere in the body, often a gastrointestinal infection like Salmonella, Shigella, Campylobacter, or a genitourinary infection like chlamydia. It's characterized by the classic triad of urethritis, inflammation of the urethra, conjunctivitis, inflammation of the conjunctiva in the eyes, and arthritis, often affecting the joints of the lower limbs, typically the knees and ankles. Oligoarthritis means affecting few joints.
And oral lesions can occur too.
Yes, patients might also experience fever, weight loss, and characteristic skin lesions, keratoderma blennorhagicum. And interestingly, oral lesions, which are described as relatively painless ulcers resembling aphthous ulcers, can occur anywhere in the mouth in a notable percentage of cases, maybe up to 17% or so, according to one source.
Okay. And what about erythema multiforme? That sounded like it could involve both skin and oral manifestations, sometimes quite severely.
Erythema multiforme, or EM, is an acute, usually self-limiting hypersensitivity reaction. It's often characterized by distinctive skin lesions that look like targets or irises, or erosive ulcerative lesions in the mouth, and potentially other mucous membranes.
And there are different levels of severity.
Yes, there are two main forms generally recognized. A milder form, often called EM minor, which frequently seems to be triggered by a preceding herpes simplex virus, HSV infection, usually about a week or two before the EM rash appears.
So with EM minor, is it almost like the body's immune response to the herpes infection goes a bit overboard and causes these other lesions?
That's the suspected mechanism, yes. An immune reaction to viral antigens deposited in the skin or mucosa. Then there's a more severe form, historically often called EM major, or sometimes overlapping with Stevens-Johnson syndrome, SJS. This severe form is more often triggered by certain systemic medications rather than infections.
Which medications are common triggers?
The sources listed several classes. Certain analgesics or NSAIDs like oxycams, propionic acid derivatives, barbiturates, sulfonamides, sulfa drugs, and some anti-seizure medications like carbamazepine and phenytoin are frequently implicated. Specific infections like mycoplasma pneumonia can also trigger EM major SJS in some cases.
And the underlying cause is thought to be hypersensitivity.
Yes, in both forms, an overreaction of the immune system is thought to be involved, potentially involving the formation of antigen-antibody complexes that deposit in small blood vessels, immune complex vasculitis, especially in drug-induced cases. In cases of EM that keep recurring without a clear cause, idiopathic recurrent EM, herpes simplex virus DNA can often be detected at the site of the lesions using PCR, strongly suggesting HSV is the trigger even if there wasn't an obvious preceding cold sore.
And clinically, EM seems to have a wide spectrum of presentations. How does it look?
It typically affects young adults more often and sometimes has recurrences in spring or fall. The classic skin lesion, if present, is the target or iris lesion concentric rings of color change. But the oral presentation can vary quite a bit. In EM minor, it might just be a few aphthous-like ulcers, maybe some lip swelling or crusting. Initial lesions might sometimes be vesicles or blisters, but they often rupture quickly, leaving ulcers. In EM major or SJS, the involvement is much more widespread and severe. You can see multiple large superficial bleeding ulcers covering large areas of the oral mucosa, often with significant lip crusting, hemorrhagic crusting.
An E major SJS sounds really serious, potentially affecting more than just the mouth.
Absolutely. EM major or SJS is a mucocutaneous emergency. It can involve not just the mouth and skin, but also the eyes, severe conjunctivitis, corneal damage, genitals, and sometimes the esophagus and respiratory tract. It can be life-threatening due to dehydration, secondary infection, and potential organ involvement.
What about the microscopic findings?
Microscopically, in the skin or mucous membrane lesions, you might see inflammation, separation within the epithelium or at the epithelial connective tissue junction, and inflammatory cells. Some sources mention seeing deposits of immune molecules like IgM, complement, and fibrin in the walls of superficial blood vessels, supporting that idea of immune complex vasculitis. In severe cases like SJS, there might be widespread epithelial cell death, necrosis. Autoantibodies to certain skin proteins, desmogleicans, have also been reported in some EM major cases.
So, the differential diagnosis, especially if the target skin lesions aren't obvious, could include things like primary HSV infection, widespread actus ulcers, or even blistering diseases like pemphigus vulgaris or mucous membrane pemphigoid.
Exactly. Also, perineoplastic pemphigus and erosive lichen planus could be considered. History, especially drug history and history of HSV, clinical pattern, and sometimes biopsy with immunofluorescence are needed to differentiate.
And how is EM treated? It sounds like the approach differs significantly between minor and major forms.
It does, and that's critical. For EM minor, especially as mild, treatment is mainly focused on relieving symptoms. Bland rinses, topical anesthetics, maybe topical corticosteroids to reduce inflammation and pain. If HSV is a known recurrent trigger, sometimes prophylactic antiviral medication like acyclovir might be given to try and prevent the HSV outbreaks and thus prevent the subsequent EM episodes.
But for EM major or Stevens-Johnson syndrome?
That requires prompt and aggressive management, often hospitalization. The first and most critical step is to immediately identify and stop any potential offending medication. That is paramount. Supportive care is crucial: fluid management, pain control, nutritional support, meticulous oral and eye care to prevent secondary infections and complications. The role of systemic corticosteroids is actually controversial. Some sources suggest they might be helpful if started very early, while others argue they might increase infection risk or aren't clearly beneficial, especially for maintenance. Topical corticosteroids with antifungals to prevent oral candidiasis might help oral lesions, but stopping the trigger drug is key.
Absolutely. Recognizing that drug trigger is vital. Now, another condition that stood out was Wegener's granulomatosis, now more commonly called granulomatosis with polyangiitis, or GPA. That sounded quite significant, especially the oral sign.
Yes, GPA is an uncommon but serious systemic autoimmune disease. It causes inflammation and damage primarily to small and medium-sized blood vessels, a condition called necrotizing vasculitis, often associated with granuloma formation. The exact cause is unknown. The classic presentation involves a triad of upper respiratory tract, sinuses, nose, ears, lungs, and kidneys, glomerulonephritis.
But there's a specific oral sign dentists might see.
Yes, and it's quite striking. A key oral manifestation, often an early sign, is what's known as strawberry gingivitis.
Strawberry gingivitis, that's a very descriptive term. What does it actually look like?
It's a very characteristic granular and hyperplastic appearance of the gums, particularly the attached gingiva. They become swollen, friable, bleed easily, and reddish-purple with small pinpoint red spots or petechiae scattered across the surface, giving them a texture and look resembling a strawberry. Recognizing this specific gingival appearance is really important because it can be an early clue to GPA, which can be a rapidly progressive and potentially fatal disease if not diagnosed and treated promptly with immunosuppressive therapy like cyclophosphamide and corticosteroids or rituximab.
So seeing that should definitely raise a red flag. What does it look like microscopically?
Microscopically, a biopsy of the affected gingiva would typically show features consistent with GPA. Granulomatous inflammation mixed with acute and chronic inflammation, evidence of necrotizing vasculitis, inflammation and damage to blood vessel walls, sometimes microabscess formation, and possibly multinucleated giant cells. And the diagnosis is often confirmed by the presence of specific autoantibodies in the blood, particularly antibodies targeting proteinase 3, which show up as a cytoplasmic staining pattern on immunofluorescence, the CANCA test, cytoplasmic antineutrophil cytoplasmic antibodies. PANCA might also be seen.
Wow, so that strawberry gingivitis is definitely something for clinicians to be aware of as a potential sign of a serious systemic vasculitis. Then there was midline granuloma, which also sounded quite aggressive and destructive.
Yes, midline granuloma, which is now understood to be a type of lymphoma, specifically extranodal NKT cell lymphoma, nasal type. It's a rare but highly aggressive malignancy derived from natural killer, NK cells, or cytotoxic T cells, often associated with Epstein-Barr virus, EBV. It characteristically affects the midline structures of the upper aerodigestive tract, the nasal cavity, paranasal sinuses, and palate.
And how does it present clinically?
It typically shows up as progressive, destructive, non-healing necrotic ulcers in this midline area. It can destroy soft tissue, cartilage, and bone, leading to symptoms like nasal obstruction, discharge, pain, and eventually perforation of the nasal septum and/or the hard palate, creating an oronasal fistula. It's a relentless, locally destructive process.
That sounds devastating. How is it treated?
Treatment usually involves radiation therapy directed at the affected area, sometimes combined with chemotherapy. However, unfortunately, the prognosis for this type of lymphoma is often poor due to its aggressive nature and tendency to relapse. It's crucial to differentiate this from other causes of midline destruction, like tertiary syphilis gumma, GPA, deep fungal infections, or even cocaine abuse, based on the clinical presentation, imaging, and importantly, biopsy results showing the characteristic lymphoma cells, often with NK or T cell markers and EBV positivity.
Okay, a very serious condition to keep in mind for midline destructive lesions. Finally, we have cyclic neutropenia, which sounded like a very specific and rare blood disorder affecting neutrophils.
It is. Cyclic neutropenia is a rare hematologic disorder characterized by regular, predictable, severe drops in the number of neutrophils, a type of white blood cell that's a crucial first-line defender against bacterial infections. The cycle typically repeats every 21 days, give or take a few days. During the low point, nadir of the cycle, which lasts for about 3 to 6 days, the absolute neutrophil count drops dramatically, sometimes to near zero.
And this has oral consequences.
Definitely. It can be inherited in an autosomal dominant pattern or happen sporadically due to mutations in the E-lane gene, which codes for neutrophil elastase.
Mhm.
During those periods when neutrophils are critically low, neutropenia, patients, often starting in early childhood, can experience recurrent episodes of fever, malaise, feeling generally unwell, painful oral ulcers, aphthous-like, inflammation of the gums, gingivitis, sometimes more severe gum disease, periodontitis, swollen lymph nodes in the neck, cervical lymphadenopathy, and increased susceptibility to potentially serious bacterial infections. The oral ulcers and exaggerated periodontal inflammation are very common features because the mouth loses its primary immune defense against bacteria during the neutropenic episodes.
So the lack of neutrophils really hits the mouth hard. How is it managed?
Treatment with a synthetic growth factor called granulocyte colony stimulating factor, or GCSF, like filgrastim, can sometimes help to shorten the duration and lessen the severity of the neutropenic periods by stimulating the bone marrow to produce more neutrophils. This can reduce the frequency and severity of the symptoms, including the oral ulcers and infections. However, meticulous oral hygiene and regular professional dental care are absolutely essential to manage the associated gingivitis and periodontitis. Prompt antibiotic treatment is needed for any infections that develop during the neutropenic phases.
So after this incredibly detailed deep dive, the main takeaway is really clear. What might appear to be just a simple sore in the mouth on the surface can actually have a very, very wide range of underlying causes. We've gone from, a minor injury like biting your cheek, all the way to infections like syphilis and TB, complex systemic autoimmune diseases like GPA and Behçet's, severe drug reactions like SJS, and even rare blood disorders and malignancies.
Exactly. It really underscores the importance of not just looking at the ulcer, but looking beyond it. Careful clinical examination, getting a thorough history from the patient, asking about symptoms elsewhere, medications, onset, duration, previous episodes, any associated systemic feelings of being unwell, and, when necessary, utilizing laboratory tests or biopsies are all crucial steps to arrive at an accurate diagnosis.
It's almost sobering, really, to realize that lesions that look quite similar, especially early on, can have such drastically different implications for the patient's health and require such vastly different approaches to treatment. Treating a traumatic ulcer is worlds apart from managing GPA or Stevens-Johnson syndrome.
Absolutely. It truly highlights the value for clinicians and even for patients themselves to understand these distinctions and to know when a simple mouth sore might actually be a sign of something more significant that needs further investigation.
This leads to a really important thought for you, our listener. Considering the diverse origins we've explored today, what seemingly minor oral complaints might actually warrant a closer look? Maybe that recurring canker sore or that gum inflammation that just doesn't quite clear up. What questions should you be asking either yourself or your healthcare provider to potentially uncover underlying issues?
Yeah, it really makes you consider the intricate connections between what's happening in your mouth and your overall systemic health and well-being. Perhaps this deep dive has sparked your curiosity about a particular condition we touched on, maybe Behçet's or EM or one of the infections. We definitely encourage you to explore its broader systemic effects, diagnostic approaches, or treatment options in greater detail. There's always more to learn.